I'm a geriatrician, internist geriatrician here in Saskatoon. This I understand is part of your neuro lecture, so you've had some discussion already on dementia, is that correct? You guys have had some teaching on that already. What I'm going to be talking about today is more approach to cognitive impairment. So when you have a person that's confused, you know, what do you need to do to get to that point where you're looking at the different types of dementia that I'm assuming Dr. Kirk taught you guys? So we won't go into a lot of detail at the end, which is more the detail, all the different types of dementia, because I'm going to assume that that was already covered, and we're going to talk more about an approach. So we're going to start with a case, Mrs. B. She's an 81-year-old woman who presents to Emerge with chest pain. She's not really responsive to nitro. She's got some ST changes on her ECG, a bit of a choke leak. Her past history is that she has angina in the past. She goes to the cath lab, they stent her, or sorry, they cath her, they don't need to do a stent. Later on in the day, you're paged to see Mrs. B, you're the Jersey on cardio or the R1, because she's confused and she doesn't want to take her medications. The nurses are concerned, they need your help. So what are you thinking when you go up to see her? What's the first thoughts running through your head as you pull out your little manual, because you got to figure out what am I going to ask when I get up there. So what are you looking at? What's popping in your head?
Would you want to do like language, orientation, naming type things?
Yeah, so what category is that? Like what are you looking at?
Cognition.
Cognition, yeah. And is there some differentials that are running through your head? Because typically when you're going up, you should be thinking, could she be having this, could she be having that, would I need to, or like these are the thoughts as you're waiting for your elevator and going up the stairs. Any idea?
I'd be maybe wondering if she's getting enough blood to certain parts of her brain, maybe
Right.
some sort of vascular dementia or something.
Yeah, so is something happening to her cognitively with blood flow and things like that. Regina, any ideas? Any other things happening that you're thinking about when you hear this story?
I would be wondering if she has like a delirium rather than a dementia.
Yeah.
So check out her blood work.
Yeah, very good. And how are you defining delirium? Just to put you on the spot. Back to Regina. Anyone want to take that one, or I guess you'll know better at the end of this lecture. Okay, so we are talking about cognitive impairment. And what is cognitive impairment? It's not just memory. A lot of people, talk about memory and they'll say, well, my grandma's memory is excellent. She can remember when I was a kid and I did this and this and this. But they could still have a dementia. So when we're talking about cognitive impairment, we're just talking about the way you think. So the way you remember things, the way you process things, the way you organize things. It's your thinking. And what we're looking for is a change from baseline. So if you've been a slowly declining person, that's very different than a sudden change, right? And so it's really important to know what were you like normally. So it's not an IQ test, it's just what are you normally like, and is there been a change from whatever your baseline was. And it's a symptom. So in older adults in particular, it's no different than, say, children where they can't communicate to you that I have pain here, or I have this here, or I'm doing this. For many older adults, the only sign that there's something happening with them, whether it's a heart attack, an infection, pain, will be delirium. That's their body's way of saying, there's something going on, come check me out. So what should be your first question? Now you're getting up there, you walk into her room. What's your first thought process when you're looking, okay, she's got it, she's confused. How are you going to start processing this and figuring out what it is? Because you're thinking, is it delirium, is it dementia?
Ask her name, ask her where she is, what floor she's on.
So orientation to kind of get a baseline of what she's like, okay. Anything else? Because you're trying to establish a baseline, right? Now, how will you know that that's her baseline? What if she always isn't oriented and stuff? So what would you have to ask then?
Do you even need to ask family members or go through the chart to see where she is cognitively sitting first?
Yeah, so to see when this change happened, right? So the first question we should be asking when you're seeing a person that is confused, so they've got some cognitive impairment, so we know they're not thinking the way they normally think, okay? So that's why you recall that. And we want to know, did this happen all of a sudden, or did this happen really slowly? So how can you tell? So like I said with this patient, how do we know what her baseline was? How do we know how quickly this happened? If the patient really is confused, they're gonna tell you everything is fine and it's all good and it's always been like this. Most of the time, they're not even gonna be aware. Unlikely if you're confused that you could say, I know I'm not quite thinking right, you know, some people might know that they're a little foggy, but generally they don't know, right? So you need to get that from history, from a chart, from the nurses, from family members, from wherever this person is from. And if you don't know, so you're seeing a patient emerge, brought in by the ambulance, found, fallen down outside somewhere, and you don't know and they're confused, you have to assume it's acute. You have to assume that it is something that just happened all of a sudden, because the causes of that, the differential behind that, it could be life-threatening. It could be an MI, it could be a stroke, it could be multiple different things, right? So you have to assume it's acute if you don't know. That's your default. So Mrs. B again, she has a past history of type 2 diabetes. She's had it for about 10 years. Hemoglobin A1C is at 6%. Her chem strip she checks once a day, and they're kind of between 4 and 8. She takes metformin. She doesn't have any kind of end organ sequelae really yet. She's had high blood pressure for about 20 years. A little bit of a drop there, but she's asymptomatic with it. She's on valsartan and hydrochlorothiazide for that. She's got high lipids for the last 8 years, is on a statin. She's broken a vertebrae about a year ago, so she's on phosphats for her bones, some calcium, and she does drink milk regularly. She also has some macular degeneration for about the last 5 years. She's been incontinent for about a year. She gets up at night once a night usually, and she's on Detrol for that. She's had coronary artery disease in the past, as I mentioned. Her LV is okay, but she is on aspirin and Plavix is added when she came to the hospital. She has trouble sleeping, and so she takes clonazepam. It was prescribed when she needs it, but she tells you that she takes it almost every night. She has some osteoarthritis in her hands and knees, and that she takes Tylenol for once in a while. And she does take ginkgo and vitamin E because she heard they were good to take. Previously been on hormone replacement therapy. Okay. She lives alone in a bungalow. She widowed about 5 years ago. She has 2 children, but they both live in Alberta, but they contact her quite often by phone. Lifetime non-smoker and drinks a glass of wine at night with her supper. Functional history, she has some occasional falls, but she's kind of vague about them, doesn't tell us a lot. She is independent with her ADLs and IADLs, and she does use a hearing aid. Her mom lived to her 90s, but did have some memory problems then. Well, I guess this wasn't supposed to show up the answers right away, but what do you need now? So, according to me, you need lab work. Probably do your basic workup, right? So you're gonna do your CBC lights for urine creatinine, your extended lights, calcium, magnesium, phosphate, albumin. What you're looking for is reversible causes, right? So you're gonna do a general screen. Hopefully from the history, you're gonna be able to add additional tests. If she's on any medication that requires a drug level, it's always good to check that. So DIG, lithium, things like that. Remember always to do a creatinine clearance in an older adult because a drug may be normal for a normal creatinine, but in a person that's older that isn't excreting their metabolites as easily, then many of the drugs are at too high a doses, so you have accumulation. So it's always important to look at that. So not just drug tox screen, but also looking at if they're getting rid of the medication. What the liver panel is, and then your TSH, B12, and glucose. ECG, you should probably do a baseline. You're going to need that as you follow the patient along. I'm not sure why all my letters are dropping off my slides, but it could be a cardiac cause, and it is one of our most life-threatening, and you need to move quickly on those. Chest x-ray, if you think that you hear anything, or she's short of breath, or there's some history around that. We do a urine on everyone that's confused, probably going to be positive. It's often positive in older adults, so you can't just stop there and say, well, she's got urosepsis or UTI or whatever, and assume that that's the cause. And then other tests as warranted. So Mrs. B, her vitals are stable, but she's clearly disoriented and she's starting to get agitated. She's very easily distracted when you're talking to her. She's looking out the hallway. Her daughter's concerned because her mom's not usually like this. So now we have a history from her daughter saying, this is not mom normally. The nurses are concerned because she seemed to be getting worse, but there are periods where she seems to be just fine. You look at her meds, and the only meds that weren't ordered on admission was her PRN benzo that she takes at night for sleep and her Tylenol. Her lab work is normal, but her UA does suggest a UTI, and she does have a folate. What's your diagnosis?